The Limit Children's Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limitchildren.org.
Our topic is acute chest syndrome, so I'm going to run us through the objectives. So before we finish this discourse or our webinar, you'll be able to identify what acute chest syndrome is. You'll be able to know the causes and the risk factors. You will also be able to know and implement appropriate treatment intervention, and also to know how to reduce the risk factors and prevent acute chest syndrome.
Okay. So I'll take in a case scenario. Here we have a 13-year-old male, known HBSS, presented with chest and back pain few days prior to admission, and cough of 2 days, but developed fever on admission. On examination, heart rate was 140 beats per minute and respiratory rate was 40 cycles per minute. Oxygen saturation was 87% in room air. On chest examination, there was decreased air entry, more on the lower lung zones and crackles. Investigations carried out, the full blood count showed WBC of 29.2 and PCV of 21%. Platelets was 205,000. Neutrophils was 53%. Lymphocytes 40%. Monocytes 6, and eosinophils 2. On hemoglobin electrophoresis, we had HbA of 6.1%, HbA2 of 3.8%, and HbS of 86.5, and HbF of 3.6%. Chest X-ray revealed bilateral opacities on day 2. Okay, so this is a chest radiograph as at time of admission. As this X-ray shows, shows slightly increased density on the left lower lung zones. Then on day 2, it showed it progressed further into bilateral opacity on the left lower lobe with atelectasis and silhouetting of the left diaphragm. So this was day 3, while on treatment and management, showed markedly improved ventilation bilaterally. As you can see, the lung zones are beginning to darken up to show more air in the lungs. Then on this day 4, opacities on the left lower lung atelectasis have resolved completely. So questions we would like to focus on: what is the diagnosis? What is the differential diagnosis? What key investigations will you do? What will be your specific and supportive therapy? And how do you follow up on patients? Okay. So the outline.
Okay, so we're going to talk about the introduction, epidemiology, how to make a diagnosis, through your history, physical findings, and then investigations, and then treatment and follow-up. So, sickle cell disease, yeah, it's common in the sub-Saharan region. And acute chest syndrome is a life-threatening complication of sickle cell disease. It's actually an emergency. And the root of the problem is that there is, vaso-occlusive crisis in the pulmonary vasculature of these individuals with sickle cell disease. So by way of definition, acute chest syndrome is defined as a new radiodensity on chest imaging that is accompanied by fever, lower respiratory tract symptoms, chest pain, and or hypoxemia. It's also good to know that it's the second most common cause of hospitalization and will also lead to significant mortality in children. Actually, in children, it leads to 1.1% mortality. So the peak incidence is 2 to 4 years. And it's also good to note that acute chest syndrome is directly related to steady state white blood cell count and inversely related to hemoglobin F, that's the fetal hemoglobin, and anemia, which means that the more the fetal hemoglobin, the less likely one has acute chest syndrome, and the more the PCV, it's at least below 30% and higher than 21%, the chances that there will be a reduction in acute chest syndrome, while the reverse is the case for the white cell count. So we're going to talk about the etiology. It's actually multifactorial in the sense that a lot could cause that. But studies have shown that sometimes it could be unclear, the etiology could be unclear. But in children, it's mostly caused by infection, viral infections and bacterial infection. And the organisms complicated in the bacterial infection is chlamydia, pneumonia, and mycoplasma pneumonia, and strep pneumonia too. Also, pulmonary infarction could be one of the causes, together with fat embolism. And these infections could come as a result of sickled red cells occluding the vessels, the pulmonary vessels in the lungs. And also, fat embolism could be as a result of fat necrosis or bone marrow injuries, which are released into the venous circulation that could trigger infections and block the vessels of the lungs. Also, it's good to know that preceding history of acute painful episodes could trigger this, especially at the back or at the chest region. It's also worthy to note that asthma could be a trigger. It could also be one of the etiologic, events that could cause acute chest syndrome. And this is as a result of, bronchospasms and other comorbidities that could lead to bronchospasms, and reduction in, oxygen level could be one of the causes. We will also not leave behind post-operative atelectasis after surgery, some sedative medications that are given to depress, respiratory centers, and could cause acute chest syndrome. In teenagers and adolescents, exposure to tobacco smoke could also cause acute chest syndrome. So 50% of individuals with sickle cell disease will have would have one episode of acute chest syndrome, yes. And I earlier said that the peak incidence is between 2 to 4 years. It's higher in winter and cold months. The cold months here is during the rainy seasons and sometimes during Harmattan when the weather is cold. Yes, sickle cell disease could cause acute chest syndrome, but the phenotype that is more implicated is sickle cell anemia. So data has shown that sickle cell anemic patients or children have 25.3 per 100 patients year to come down with acute chest syndrome, while those with HED-PSC has 1.9 per 100 patients year, and beta thalassemia, 3.27 per 100 patient year. So in Nigeria, 5.9%, there's a prevalence of 5.9% of acute chest syndrome in Nigeria, and Cameroon, we have like 6.2%.
Okay. So, regarding the pathophysiology, there's massive deoxygenation of the HBS with the polarization and sickling of the red blood cells, and this can lead to vasopression, ischemia, and endothelial injury. And subsequently, also vaso-occlusive crisis of the spine, ribs, and abdomen, and use of opioids. This can result in hypoventilation, which can further lead to alveolar hypoxia due to reduced air filling, plus decreased tidal volume, and hence can lead to lung collapse, atelectasis, and EP mismatch. Other complicating factors include inflammation, fat embolism, pulmonary edema, and bronchospasm. Now, this is more of on the macro pathophysiology. Then more in depth. So, due to the decreased oxygenation, this causes a polymerization of the erythrocytes, and this hence leads to the sickling and clumping of the red cells. And during this sickling and clumping of red cells, they tend to release some certain proteins, which are the alpha-1 and beta-1, which subsequently bind to the VCAM receptor on the endothelial cells. Now, normally there's nitric oxide, which inhibits this procedure, but in the case of sickle cell, the nitric oxide is consumed due to the breakdown of the cells, and during this causes vaso-occlusion and hence reduction of blood flow. Now, it further leads to this reduction of blood. This reduction of blood flow also leads to reduced flow, blood supply to the bone marrow, and this can cause bone marrow necrosis and subsequently causing release of some fat globules and secretory phospholipase, which subsequently travel towards the lung vasculature and causes occlusion there and infractions. Thus, can also be compounded with pulmonary infection and subsequent resulting, and also in addition to possible hyperventilation from maybe due to pain from the chest pain or back pain, hence leads to hyperventilation. All these compound and further causes increment or impact in the pathophysiology. Then also due to the reduced, there's already occlusion to the lung vasculature and the subsequent shunting of blood from the lung vasculature. It can now also lead to further hypoxia and desaturation, which now goes back all the way to reduced hypoxia and increased hypoxia and reduced oxygen flow, goes back into a sort of vicious cycle that causes further sickling and polymerization of the red blood cells. So diagnosis, basically a history, a high index of suspicion is required, and aim is for early detection and prevention, as this improves the prognosis. So we want to rule out complaints of fever, cough, respiratory distress, acute painful episodes, progression of symptoms, altered mental status. In the case of where the saturation is being decreased, it's one of ways can show is where altered mental status. That a particular rash, which could be more of a sign of something insidious, maybe due to an infection, a viral or bacterial infection. They also want to rule out symptoms of bronchial spasm, such as asthma, either present or in the past, as patients with sickle cell patients with asthma have a 2 to 4 times more chance of developing acute chest syndrome. They also want to rule out history of opioid use and fluid overload. So in physical examination, we want to establish the vital signs. Of course, we are looking for the heart rate, respiratory rates, the oxygen saturation. Also look for chest signs on auscultation. We want to know is there any crackles or is there any reduced air entry on chest examination and auscultation. Then for oxygen saturation, we of course want to observe saturation. If it drops below 92, this is evident, or this need for immediate oxygen commencement and care. They also want to check the hydration status, as dehydration can be one of the causes of crisis, VOC crisis, which can also further lead into progress into acute chest syndrome. Then degree of pallor, also check for evidence of infection and neurological exam. So some of the investigations require a daily food log count so as to compare with the baseline, then liver function test and serum urea, electrolyte urea and creatinine. Also, this can also be used to also establish a sort of baseline for the patient scene. Then a serial X-ray from moment of admission down how long as they recover, so as to see the progress of treatment and ensure that the treatment is adequately going well. Then blood cultures to find out to isolate the cause of infection or the pathogen implicated in infections. Then also possible culture of other sites such as urine or stool or any wound swab or any body, let's say any body swab generally. Then continuous pulse oximetry. While the patient is on oxygen, you want to continuously ensure that saturation is optimal at any point, so that if any increased drop, one knows when to really intervene into it. Then a group and cross match for blood, because blood transfusion is one of the key points of management.
Okay, I just want to throw more light on the investigation report, especially the baseline of the food log count, which we're supposed to know. So once these children or warriors come to you, you're supposed to know their steady state PCV, their steady state white cell count, and their steady state thrombocyte count, because it will also guide you on when there is problem, how to intervene. Okay, now based on what we've discussed in the pathophysiology of acute chest syndrome, about the production from the bone marrow and all the secretory phospholipase A2, which is being produced, that will now trigger actions of the production of free fatty acid that occlude the vasculature or the pulmonary vasculature. So this causes a pro-inflammatory responses, yes, but there's a correlation, because the more you have that secretory phospholipase A2 produced in the system is actually a predictor of acute chest syndrome about to happen. So another correlate that one can use to monitor or to decipher when acute chest syndrome, the risk of it coming up and all, is the C-reactive protein. So if a C-reactive protein is done at the time of admission and it is elevated, at least maybe more than 5 milligrams per TL, then it gives you a clue that something, senile or impending acute chest syndrome is about to happen. Then the other things is that the liver function test and the serum electrolytes, we should also know them when they come to us, maybe for the first time, so that we also know what the baseline is like, so that when there is problem, you know what to fall back to and how to address it. So grouping and cross-matching is, we always have to know that in case there's need for transfusion, so that, you buy time in management.
Okay, so on the diagnosis, so the criteria basically is there new radiographic density on chest X-ray involving either single lobe or multi-lobe, and or pleural effusion, and at least one of the following: fever of greater than high-grade fever of 38.5, greater than 38.5, or a greater than 3% decrease in oxygen saturation from a documented steady-state value in room air. Tachypnea, of course, should be adjusted. This respiratory should be adjusted by age. Intercostal restrictions, nasal flaring, or use of accessory muscles in respiration, cough, chest pain, wheezing, and rales. So a high index of suspicion should be maintained in patients with chest symptoms and signs, including hypoxia, even in the presence of a normal chest X-ray.
Okay, so we're going to dive into the treatment. So it should be prompt. Treatment should be prompt. Once you get them early, the risk of having prolonged hospital stay is reduced, and the risk of disrupting deterioration and progression is also reduced. So prompt treatment is the goal for correction. So we correct the underlying factors, anything that could lead to deoxygenation and dehydration, you get, that could, consequently result to ischemic and injury to the lungs. We attack or tackle that. So I'm going to talk about specific treatments. I'm going to divide my treatment into specific and supportive. So my colleague talked about, vitals, physical findings, what to look out for, and mentioned checking the hydration status. So in acute chest syndrome, the way you manage acute painful crisis, when they have painful crisis, the way you hydrate them is actually different from the way you manage acute chest syndrome, especially when they come with chest pain, maybe dyspnea, or have desaturation. It was like, oh, maybe it's the pain that is causing, maybe, rib pain, back pain, or something that is making them unable to breathe well, and it's VOC, and then you quickly go into hyperhydration. No, it is not so with acute chest syndrome. Maintain adequate hydration by ensuring that you know the status, the hydration status of this child, and you avoid overhydration. You don't, give that liberal fluid intake as much, because you don't want a situation where the child is overloaded and they will now, go into sorting out pulmonary edema. But in case that happens, you could quickly give furosemide to, diurese and remove the fluid accumulations. Also, I'm going to talk about pain control. Some studies say you could use morphine or ketorolac. Ketorolac in the sense that it is less sedating, because you don't want a situation you give, sedatives, that medications that will sedate and reduce, the respiratory centers and cause hypoventilation and cause more hypoxemia that will worsen the, acute chest or the morbidity that the child came with. And the dose of the ketorolac is 0.5 milligram per kg IV, and you don't exceed 30 milligram. So as you're doing that, you're monitoring the patient, and it's supposed to be given for 3 to 5 days as you, monitor closely. I said earlier that ketorolac is actually less sedating. It's also worthy to note that it also, is an NSAID, it also has its side effects. So you weigh the benefits and all, and be sure it is given cautiously because of the other side effects. So adequate analgesia should be given for, spine, thoracic, and abdominal pains and all. And how do we do that? Okay, in our physical findings too, we are supposed to also check the pain score, and then have a, check the pain score and grade these pains, and it will now give you, idea of how to use the painkillers. And remember, I said earlier in my previous slides that in children, that the most common cause of acute chest syndrome is infection. So all patients must receive antibiotics, preferable third generation cephalosporins and macrolide. And the macrolide here is azithromycin 10 milligram per kg, but the national guideline for, sickle cell that just came out said we could use clarithromycin. That is also another macrolide that one could use in treating acute chest syndrome. And you know what our targets are: the atypical microorganisms implicated in acute chest syndrome, together with the cephalosporins. Also, if there is maybe more culture is done and we have like methicillin resistant staph cultured, one can, use vancomycin. If there is other alternatives to use aside from these medications that I've mentioned, the antibiotics I've mentioned, is the quinolones, the ciprofloxacin and the levofloxacin could also be used. So fever is taken care of with paracetamol, so you control the fever. Also, in those with asthma, Bronchodilators had also been, scheduled doses of bronchodilators could be used. And here is the dose, 5 milligram in those that are greater than 5 years and 2.5 milligram in less than 5 years. And it should be a nebulized, bronchodilators, which we use for nebulize for 10 to 15 minutes, observe, listen to the chest, and you could give, up to 3 doses within an hour. Yeah, steroids. Depending, steroids, some studies said that steroid actually reduce the, hospital stay, reduce the duration of hospital stay for these children or patients with acute chest syndrome. So a short-term course of steroids, 0.3 milligram per kg per dose, could be given 12 hourly. You give like 4 doses over 48 hours. Or prednisolone, oral prednisolone can be given 2 milligram per kg per day, 5 to 7 days. It actually helps, reduce hospital stay, but there are some studies that have shown that it could cause rebound hypoventilation, and also as we are using that, we should also be cautious. Antipyretics, I've talked about it. When there is fever, you need paracetamol to, handle that. So we are going to talk about the other specific treatment, which is blood transfusion. So the blood transfusion, we are going to have it under simple blood transfusion and exchange blood transfusion. So when we have done this, managing the pain, hydrating, giving bronchodilators for those with bronchospasms, and also steroids to, reduce inflammatory responses and all. Blood transfusion is the next when all this fail. And the simple blood transfusion, what it actually does is to improve oxygenation and reduce the rapid deterioration of acute chest syndrome. So you could see that from our case scenario, when the 30-year-old boy was admitted, there was actually, it was almost a clear chest, radiography that was picked. But by the second day, because it's supposed to be a serial chest X-ray done, by the second day, there were all infiltrates all over the lung zones. So acute chest syndrome, if it is not, promptly managed, or, high index of suspicion, and you're aggressive with the management, if that is not done, there might be some rapid deterioration. So blood transfusion aims to increase the packed cell volume to 30%. That is the maximum you should do, and that's equivalent of 10 to 11 grams per DL. So indication for simple transfusion or top-up red cell or packed red cell transfusion here is oxygen saturation less than 92%. So let me just, stay a little on this oxygen saturation. In any child with sickle cell anemia or sickle cell disease, our target saturation should be 95%, except the child is a patient that has low oxygen saturation, even in steady state. So our target is to keep it at 95%. But top-up transfusion, once you have oxygenation of less than 92%, is an indication for simple top-up transfusion, or hemoglobin of less than 7 grams per dl, but the current guideline says less than 6 grams per dl, we do a top-up transfusion. And then when there is an, increasing anemia, a rapid drop of 10 to 20% PCV, or drop of 2 grams per dl in the hemoglobin from the baseline of the patient, you do a top-up transfusion. So, and this decreasing PCV during hospitalization, I just talked about that now, and then clinical or radiological progression of the disease, but with no impending respiratory failure, because when there is impending respiratory failure, that's where exchange blood transfusion comes in. And also you can, give a top-up transfusion when you want to do an exchange blood transfusion, but things are not well set for that. So as a temporizing measure, while waiting for exchange blood transfusion, one can quickly do a top-up transfusion and then subsequently carry out the exchange blood transfusion. So indications for exchange blood transfusion is if the acute chest syndrome progresses despite the simple transfusion, that's a simple top-up transfusion, or when there is severe hypoxemia, there is multilobar disease, there is segmental infiltrate, and there is progression of acute chest syndrome. Also, when there is previous history of acute chest syndrome, because in children, one of the complications, although we'll talk about it, is that there is always a reoccurrence. Once they have acute chest syndrome, we tell them that there might be a reoccurrence. Then when there is a rapid progressive or even multi-organ failure. So it's good to know that progression must be prevented. So you don't even want it to get overwhelming or get out of hand. So progression must be prevented by vigilance for symptoms and prompt escalation of management. So monitoring in these children is actually key. So now, other therapy, the supportive therapy, although some studies say that even if the saturation is within normal, just start oxygen therapy, because there are some, that the oxygen saturation is normal does not necessarily mean that there might not be, a focal lung injury or hypoxemia that is actually maxed. So respiratory support is key. So you start with intranasal oxygen. When it's overwhelming and there is no, the child is deteriorating, you can switch to continuous positive airway pressure or intubation in worst case scenario, or ECMO. It's also good to note that while you're on admission and they could even talk, or, for you to prevent lung collapse and all, you have to commence them when they have strength and they are maybe fair enough to have intensive spirometry done. They are fairly stable. You can, commence them on intensive spirometry, which, they do every 2 hourly at 10 to 12 breaths. So you can use the spirometer or you use a balloon. I've talked about CPAP when there is rising need for oxygen and respiratory effort. So these are the indicators when a child is on admission to show you or let you know that there is poor progression. There will be worsening hypoxia. There will be increased respiratory rate, decreased platelet count, decreased heart cell volume. Then there will be more involvement of the lobes of the lungs on chest X-ray. Then neurological complication, drowsiness, sleepiness, seizures, or other neurologic complications that could result from hypoxemia.
Yeah. So I'll be talking differential diagnosis. So some differential diagnosis that can be noted that with similar symptoms, or similar presentations as acute chest syndrome. This includes acute chest infections such as pneumonia. Pneumonia in particular tends to be quite difficult majority of the time to distinguish between pneumonia and acute chest syndrome. And in some cases, the pneumonia tends to precede the acute chest syndrome. Starts then along the line in a section, along the line the acute chest syndrome develops also. So you can also say that it can be a cause, also involved in the cause of it also. So it can present basically with the cough, the fever, the worsening hypoxia, and also on the chest X-ray, it's been noted that they also have some patchy infiltrates. So all on X-ray also causes a difficulty in being able to differentiate whether this opacity, this hyperdensities are from a pneumonia or if it's from the acute chest syndrome. Then others can be from pulmonary embolism, from a DVT. So one can note a prolonged period of immobility, and also in pulmonary embolism, most of the time the hypoxia that results or difficulty is normally quite sudden in onset. It's really as insidious as pneumonias or the possibility of the acute chest syndrome. It's very quick and immediate. Now, the other differential is acute severe asthma. They also present with the cough, the hypoxemia, and the basically difficulty breathing, but also like I said, the asthma can also be a precipitant of the acute chest syndrome. Rather, it can also be one of the things that puts them at risk because of, I said earlier, sickle cell patients with acute with asthma tend to have like a 2 to 4 times more predisposition towards getting the acute chest syndrome. Then in case of vaso-occlusive crisis also, so the chest pain from maybe the VOC or VOC of the ribs or VOC of the vertebrae can tend to present like chest pain from the acute chest syndrome, but also it can also be one of the things that also predisposes them towards it. So they present, basically their main comparison between them is the pain. Though of course on chest X-ray, as at the presentation, the chest will appear, chest X-ray will show clear lung films. But then again, also in the beginning stage of acute chest syndrome, like I was saying in the earlier case, in the case study, the chest, only the left lower lung was affected, but in some cases, the chest can actually appear clear at first, then subsequently now progresses. And when a repeat X-ray is done, one notes that there's opacity all around the chest X-ray.
Okay, let me add more to this. So for the pulmonary embolism from DVT, is seen in older people? Yes. Or in a child that is immobile or, had been on admission for a very long time and all that, and is not on maybe anticoagulant or stuff to, prevent embolism. Then in acute severe asthma, there will be a family history or a positive history of the child having asthma, being a non-asthmatic, or family history of anyone with asthma or allergy or atopy, and also with the following other symptoms that my colleague talked about, and also triggers you get. So that would also help you differentiate between this is an asthma and this is an acute chest syndrome. Then the severe vaso-occlusive crisis. Yes, especially those ones that are within the rib cage or at the back that will not allow them breathe well. So when you do an X-ray, because those ones could be as a result of infarction of the bones around the thoracic region and all, but you might not pick up these new infiltrates on radiographic imaging that they do and all. So, and also once you give painkiller and it stops, that means it is what it is. It's a VOC, or severe, yeah, you manage with analgesia and hydrate properly.
And long-term complications of the acute chest syndrome involve recurrent acute chest syndrome. So in this scenario, with every occurrence of acute chest syndrome, it predisposes them to a possible, whichever episode they are predisposes them to another or to possibility of more episodes due to constant lung infections that reduce, let's say, area of viable lung to say, or increases possible areas of hypoxia. Then also with interstitial lung disease, due to the recurrent inflammation and infections, it can cause scarring. This can result in possible scarring and fibrosis of the lung tissue, hence leading to the possibility of interstitial lung disease. Then pulmonary hypertension. This is one of the, let's say, very dangerous complications of the acute chest syndrome. Due to this occlusion of the vessels of the pulmonary circulation, including the arteries, this can cause increased increased pressure around the pulmonary vessels and vasculature, and this can also possibly result in to put more strain on the heart, hence leading to possibly heart complications later on. Then risk of death. The acute chest syndrome is one of the practically the most common cause of death in sickle cell patients, but are also the second most common cause of hospitalization. So it's quite essential to know that it's actually something that should be taken quite seriously, or as a presentation, also be considered seriously as presentation.
Okay. Okay, let me just pause for a while. Please, if you have questions, please leave it at the question and answer box, because we are actually coming to the wrap, so that we will take your questions. Thank you so much. So follow-up. Survivors are followed up for a long time, and our goal is to prevent reoccurrence and monitor them gradually and ensure they don't have these complications that my colleague just mentioned and even more. So how do we do that? Prevention, prevention, prevention. So prevention of infections that could trigger acute chest syndrome. Yeah, we talked about the viral and the bacterial, but I'm going to dwell on the pneumonias. So appropriate childhood immunization, the pneumococcal vaccines are given to them when they are 2 years of age, and subsequently these special vaccines are continued. And oral penicillin B is also commenced when they are less than 5 years, although some studies say that depending, you can do that till they are 7, but they are supposed to be on oral penicillin B from possibly 6 months or 1 year of life till they are 5. And what this does is to prevent them from coming down with infections from pneumonias. So we also, encourage them about pulmonary function test, which is done every 2 to 3 years. Then monitor their pulse oxygen saturation by periodic, oximetry and the pulmonary function test. This also should be done more in those with asthma that have sickle cell diseases here. Bronchospasm should be detected and treated earlier with bronchodilators, even though maybe they should be on, for those that are asthmatic, they should, see their pulmonologist and also have their therapies and their inhalers, nebulizers handy. And it's also good to detect and treat pulmonary hypertension as early as possible. So I'm going to talk about the use of hydroxyurea after treatment. Now they are well and they are home. You prepare them for, commencement of hydroxyurea, because acute chest syndrome is actually one of the deadly or life-threatening complications. So you don't want them to have a reoccurrence. You commence them on hydroxyurea. Parents are carried along. If the child can consent and is a teenager, can understand what you're talking about, a child that could understand you. So you talk to them about hydroxyurea. Health education should not be overemphasized. So you talk to them about this medication, what it does, how it will be helpful. So what does it really do? What it does is to reduce the risk of sickling. And how is it done or achieved? You commence, once you commence it, what it does is to reduce the, it actually increases, number one, it increases the fetal hemoglobin, yes, increases the PCV, and sorry, increases the PCV, and also reduces, vaso-occlusive crisis. It increases the nitric oxide production. Then anything that could cause hyperviscosity or polymerization or attachment of cells to the pulmonary lining or the vasculature, it reduces that. So thrombocytes, the platelets, it reduces it. And then, they always have elevated white cell counts, yeah, when you compare them with children without sickle cell, yes. So it also reduces that and now prevents, the adhesions and, adhesions of the blood cells to each other and to the vascular wall. So that's what, majorly, what it does is to increase the fetal hemoglobin, which has more oxygen affinity than the sickled hemoglobin and even the adult hemoglobin. So if the hydroxyurea fails, we will switch to chronic transfusion, which one should start. But some facilities or some studies give them hand in hand, commence the hydroxyurea and also starts the chronic transfusion, which is the exchange blood transfusion for some months, 4 to 6 months, to prevent reoccurrence of acute chest syndrome. So for multiple acute chest syndrome, example more than 2, hematopoietic stem cell transplant is actually recommended. And it's also worth to know that, they said, some studies said that, it reduces or even it has like more than 80% of benefits in children with sickle cell disease. Okay, so as we wrap up, I will just briefly talk about the risk factors. So one of the risk factors is younger age. We talked about 2 to 4 years. Very low PCV. Those that have very low PCV, that's why it's worthy to note their steady state PCV. And then when there is severe anemia, it is one of the risk factors. Then lifestyle behavior, smoking, and all, especially in adults, in children with sickle cell disease, and thrombocytosis, all those, and leukocytosis they are risk factors. They are things that could, aggravate acute chest syndrome. So I think we have come to the end of our discourse. So going back to the case scenario, we'll be able to note or make a diagnosis and also know what to do when we have a case or we see a case of acute chest syndrome in our facilities. Thank you so much. So the floor is open for questions. Thank you. So you can put it actually in the question box. Thank you so much. Okay, we are going to take your questions. Thank you so much for your time, and thanks for listening to us here. So how do we balance the need, anonymous attendee, how do we balance the need for opioids in treating vascular occlusive crisis with the risk of hypoventilation that may lead to acute chest syndrome? Okay. Remember I said earlier that ketorolac is actually the recommended medication in acute chest syndrome because it's less sedating, yes. But you will weigh the risk and the benefits and be sure that this child that the saturation is being well monitored, yes. And even if you're giving an opioid, you're going to give a low dose opioid. But balancing it with VOC crisis from any other cause not the one that is related to acute chest syndrome. That's if I understood your question. Opioids are not used when there is mild pain. It could come in when there is moderate pain. You know, when there is moderate pain, and that's when you bring in the dihydrocodeine, the DF118. But the morphines and the pentazocines come in when there is severe pain. So now, in treating acute chest syndrome, because of the risk of hypoventilation, one needs to be very, very cautious. So you use your clinical acumen and discretion, but the first line painkiller is actually ketorolac. Then you could add opioids by the side. I hope I'm able to answer that. Please, could you kindly tell us analgesic options available for managing sickle cell crisis in patients that cannot take NSAIDs and in who are at risk of opioids dependence? Okay, there are other medications aside from ketorolac, the NSAIDs, they are all ketorolac, diclofenac, they are all NSAIDs that could, you know, affect the kidneys or cause dyspepsia for those that are on it for a very long time. So there are other medications, but they are all high drugs like the fentanyl. And well, when I remember those ones, I will, you know, let you know the risk of opioid dependence and not on acid. You can do the paracetamol or the other higher medications, depending. Is it a recommendation that all sickle cell patients in vaso-occlusive crisis be placed prophylactically on intranasal oxygen to avert acute chest syndrome? No, it's not. You know the features of acute chest syndrome, right? Fever, especially in children, fever, pain, respiratory symptoms, cough, chest pain, difficulty with breathing. It is actually not, but some studies will say, there might be a masking of, you know, hypoxic lung injury somewhere that could be, your saturation might not be able to, you know, give you a positive, what do you call, is it false negative result or false positive? Yeah, but it's just a high index of suspicion. You should have a high index of suspicion of acute chest syndrome. Watch maybe the age of the child, 2 to 4 years, and also even adolescents can also have acute chest syndrome. I've managed some with that, but it's to be on the, you know, side of caution. You can give, but it is not a recommendation for, you know, like a prophylactic recommendation. No, it's not. You can't hear any sound. Pulmonary embolism is not common in children. Thank you. When a patient is unaware of his or her baseline values for white cell count, PCV, and platelets, how should the care team proceed? So once they leave the hospital, or they, you know how to check the steady state when there is no crisis. In the some say 2 weeks, other studies will say 4 months. But when there is no crisis and no blood transfusion in the next 3 months, one can be able to check their baseline, and when they are, you know, stable, you'll be able to check that if it was missed when they presented them, when they were stable and presented to you, or if you catch them when they are already sick and you're unable to get their baseline. It's also good to note that aside from the white cell count, platelet, and the fat cell volume, we also have a baseline of their oxygen saturation. What are the long and short-term complications of hydroxyurea? What is the implication of the suppressive effects of hydroxyurea on neutrophil and other blood cells? Okay, long and short-term. Depending, there are studies done, although parents were, apprehensive about commencing hydroxyurea because it's a suppressive, it's an immunosuppressant that they are, the child could come in or could have infections, risk of having the malignancies and all that. But studies have been done and showed that hydroxyurea is of more benefit than the complications that had been, put forward because of its, immunosuppressive effect. And but when it is being stopped is when maybe, especially in female patients that are about to have their babies. So it's stopping at 3 months before conception because of the teratogenic effects that it has. But apparently in all, hydroxyurea is a go for any child with sickle cell disease, because although for those that could tolerate it, because it's not all patients that are able to, that tolerate hydroxyurea. So it actually starts working from 3 months to 6 months. If there is no improvement or effect, positive effect, or maybe the patient reacts to it or doesn't tolerate it, then it's been taken off. I wouldn't mind if you could share the resources on the use of salbutamol nebules on acute chest syndrome. Okay, my offering first was that those that have any bronchial spasms or subjects that, because some of them, the patients with some of the patients with sickle cell disease could also have a comorbidity of asthma. I've seen one before that is a non-asthmatic and a sickle cell anemic patient that didn't actually have acute chest syndrome, but they could have some comorbidities. So that's where the salbutamol nebules come in. It comes in when there is bronchial spasms, symptoms of bronchial spasms, or in those with asthmatic attacks, or those that you want to prevent from having bronchial spasms. That is when it comes in. But some studies say that the benefits are, really not much, but it just decreases hospital stay. Can hydrocortisone be used in treatment instead of dexamethasone? I didn't see any article that says hydrocortisone could be used, but the most beneficial is dexamethasone and prednisone. Are there facilities that perform stem cell transplants in Nigeria? There is one coming up. Just watch out for this space. It might be us. Just watch this space. But there will be one coming up soon. Thank you for the presentation. How do we make a diagnosis of acute chest syndrome in a non-HBSS patient who present with features of respiratory tract infection as well? Okay, I think you talked about it, right?
So basically, in the case of respiratory tract infection, most of the majority of the time, it's quite difficult to actually differentiate them, because even on the chest X-ray, in case of pneumonia, they appear almost alike. However, since they still basically follow nearly the same line of management, so compared to the antibiotics, the intranasal oxygen. Now, also at times, or a good number of times, the respiratory infection tend to precede the acute chest syndrome, or precipitate or result in the acute chest syndrome, basically. So it's more of while managing the respiratory tract infection, you still put into consideration the acute chest syndrome and manage as well, basically.
Okay. Some of these, pneumonias or chest infection, pneumonia, lung inflammation from, infection, viral or bacterial. But acute chest syndrome is actually because of the infiltrates or like infiltrates from sickled erythrocytes that occlude the pulmonary vasculatures and all. So pneumonia infection could actually predispose or get one or make a patient with sickle cell come down with acute chest syndrome. So radiologically, there might be a consolidation that, we prep you that this is a pneumonia. Do you get? But in acute chest syndrome, yeah, you can see some opacities, but it's kind of progresses. It progresses quickly with hypoxemia. So although there is an overlap, that's my offering or what I know. When you talk about new infiltrates, how do you confirm the infiltrates you're seeing on X-ray is not an old one when you don't have a prior X-ray of a patient to compare with? Because some of these patients may not be previous X-ray while seeing them due to poor presentation to hospital and radiograph. Okay. Chisel, enema. From our investigations and the case scenario that was presented earlier, how you monitor progress is serial radiologic imaging. So when they come, they might even come without any opacity or any infiltrate, but on admission, the next day you're seeing infiltrates. Then the third day, if it's not well or properly managed, it keeps changing and deteriorating until you now see, opacities all over the place. So it's not maybe you should have, I'm not talking about you having a steady state radiologic finding that is normal, then on presentation, then you now keep seeing infiltrates. No. As they are on admission, there might be none. The next day, you're seeing infiltrates. The second day, it's getting worse. They are desaturating. They can't even talk. You understand? They are hypoxemic. So that is the cause. If there's no aggressive management, that is what one could see. Is there any medical benefits of use of dexamethasone in sickle cell when they are in the state of hemolytic crisis? Well, we're talking about vascular occlusive crisis. Hemolytic crisis, although there are some inflammatory responses here and there, but it's just, there's really, from studies I've seen, although it's not what we're discussing here, using dexamethasone in hemolytic crisis, I don't think there is so much benefit using dexamethasone to manage hemolytic crisis. What is the prerequisite for initiation of hydroxyurea? Okay, initiating hydroxyurea, one, when there is complications. The complications are acute chest syndrome, stroke, hepatic involvement, sickle cell disease cardiomyopathy, and recurrent vaso-occlusive crisis. So clinically, or maybe based on the complications. Then secondly, in those that maybe their parents, accept to commence the child on it, you can do that. Or you can also use your clinical discretion. But before you start the hydroxyurea, you're supposed to inform them, talk to them about the benefits of hydroxyurea, the side effects of hydroxyurea, and that it's a drug they're supposed to be on a long time. and should not be stopped except your health care personnel tells you to. And the prerequisite investigation or the investigations you do before you commence the hydroxyurea: have a steady or baseline food blood count, have a baseline what's it called, HB quantification, do a liver function test to know that the hepatic enzymes are good, that the liver is functional and will be able to handle the hydroxyurea, like excretion and all. Also ensure that renal function test is done, because those are some of the contraindications to hydroxyurea. Those that have renal impairment, hepatic impairment, we don't actually start them on that. So you ensure that these 4 investigations: food blood count, electrolyte kidney function test, liver function test, and then HB quantification is done, then you know your baseline and start. Okay. Dr. Martin, if you have any other, I'm just be strolling and be looking for questions. I think we are done. What time is it? Okay, I don't know. I guess I'm able to answer your questions. So the slides will be ready on Monday. It will be sent to us. Then if I'm unable to answer your questions, I don't know if I do not touch anyone, but if I'm unable, you can still send them WhatsApp message. Then I will, yes, join the WhatsApp group and I will send you your answers there. Thank you so much. Thanks for your time. Bye.
Okay.
So join us next month. Bye-bye.
The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.